Thank you everyone for joining this webinar. The purpose of this presentation is to discuss the forthcoming revision to ANSI NEMA SC1, American National Standard for Vendor Credentialing in Healthcare. So, NEMA, the National Electrical Manufacturers Association, in conjunction with its subsidiary, the Medical Imaging and Technology Alliance, was convened stakeholders to revise this standard to reflect the new emerging needs from the COVID-19 pandemic. The purpose of this discussion is to discuss the updates to the standard and hear from various stakeholders their perspective on the need for this work. NEMA-MITA is a standards development organization accredited by the American National Standards Institute. A standard is a document which tells you how to do or say or make or test or organize or design something. An American national standard carries with it certain requirements for due process, making it a document which is approved by a broad consensus group in a transparent process. ANSI has essential requirements which govern the process by which standards developers are accredited by ANSI and the standards which are developed via those processes. Accreditation by ANSI signifies that the procedures used by the standards development organization carry with it the essential requirements for openness, balance, consensus, and due process. NEMA has been accredited by ANSI, and MITA is following NEMA's accredited procedures. ANSI defines consensus as substantial agreement by directly and materially affected interests. Consensus signifies the concurrence of more than a simple majority, but not necessarily unanimity. It requires that all views and objections be considered and that an effort be made toward their resolution. In this case, NEMA, our accredited procedures require approval by at least a majority of the canvas list and at least 2/3 of those voting, excluding abstentions. So the process that we undertook was to revise ANSI NEMA SC1. And in order to undertake this revision, we convened a multi-stakeholder working group comprised of medical product vendors, healthcare providers, regulators, accreditors, trade associations, vendor credentialing organizations, and others. We met weekly to iterate on a draft document, eventually getting to a point where we felt comfortable balloting this draft document to a consensus group of diverse interests. The consensus group moved to approve the revision to the standard in question, and we anticipate final publication of the document in the first quarter of 2021. We will now hear from the Consortium for Universal Health Credentialing on their perspective for the need for this standard.
Thank you, Peter. My name is Rhett Surrey. I am the past chair of the Consortium of Universal Healthcare Credentialing. Just a very high-level overview of credentialing. Most of the audience members probably know this, but credentialing is a process that supplier representatives must go through prior to access to a customer's facilities. The requirements vary significantly, but in general, they include administrative requirements like background checks and drug screens, training requirements, medical surveillance, which we'll touch on a little bit later in the revision, and then some non-standard requirements, including PPE, which is one of the main reasons that we reconvened the Canvas group. So in the world of credentialing and in the two specific issues we're going to discuss today, there are some challenges and concerns with the credentialing requirements. Obviously, if there's non-compliance, it creates some reputational risk for the organization, both organizations involved. And it could also create some business opportunity loss, whether procedures are delayed or canceled. Some of the requirements also include some personally identifiable information or some personal health or protected health information that could butt up against some of the data security privacy laws. There are some also concerns about how some of the information is used and the implication it has with other laws. Because it's challenging, sometimes we do have inaccurate and outdated information, and it also results in a lot of duplication with wasted labor and spend. Our current estimates that there are about $2 billion a year spent in incremental healthcare costs related to credentialing. COVID kind of highlighted some additional challenges with credentialing requirements and inconsistency, which has had or could have a negative impact on patient services. So ultimately, we have to remember that we're all there to support the patient, and the patient could be negatively impacted. So the revision to the standards included two main areas, PPE and wellness screening additions. We felt that it was important to reconvene the Canvas group because at the onset of the pandemic, understandably, there were some significant challenges in the procurement of PPE and also screening to ensure that we were not creating any additional risk for our patients. Unfortunately, this was compounded by the fact that there were some limitations in the amount of PPE globally. So each institution understandably tried to create a process in order to manage through some of these challenges, but the inconsistencies actually created some additional challenges. As an example, some providers would require the individual to bring their own PPE. In other institutions, they were not allowed to bring their own PPE. So the result of that is everybody was trying to procure very limited supplies of PPE, which only exacerbated the problem. The other issue that we had was with the wellness screening and whether COVID testing was required, what types of temperature checks were being done, just some inconsistencies in the screening that was done for the individuals. So to that end, these are the standards that we added to the ANSI standards SC1 in the current draft mode, which Peter alluded to will hopefully be published in January. So the standards include the novel virus and communicable diseases. So we wanted to try to draft this so that it could apply to any other novel virus or communicable disease, not just COVID-19. So what we defined is in those situations where there's not a definitive test or some kind of a vaccination to prove immunity, that there should be some screening done for those individual for general wellness exposure and specific symptoms. They're listed here, as you can see. And as far as documentation, the acceptable data standard would be an attestation from the supplier representative that they do not exhibit any of these symptoms. This would be done on an ongoing basis whenever the individual is accessing the healthcare facility. And then we also tried to add some language that would state that once there is an FDA approved or CDC recommended method for documenting immunity, or a viable vaccination was available, that these standards would again be revisited to reflect the documentation versus the wellness screening, similar to measles, mumps, rubella. The other standard was along the lines of personal protective equipment. As I mentioned earlier, there were some inconsistencies which led to competition for PPE that was in very, very short supply. So the recommendation per the Canvas group is that the representative will comply with all requirements for PPE as applicable to all patients, visitors, and staff. And the requirements can be satisfied with vendor supplied PPE. For tier 2 and 3 access, the facility can determine the appropriate PPE requirements consistent with the CDC, OSHA, and other government guidelines. And then provide that PPE for all personnel. So for general access, it's the standard PPE that is required for all individuals. Once we get into more sensitive areas, then the facility is a subject matter expert in that area and will provide the appropriate PPE for that circumstance. As far as the close-fitting respirators and fit testing for N95 masks, the requirements shall be consistent with the CDC and OSHA guidelines. And the fit testing would only be applicable to those supplier representatives involved in activities where the N95 mask is required. In emergency situations where there is a shortage of PPE and the provider is unable to provide the PPE, in those instances, the supplier may be able to supply their own, but again, following the current and applicable CDC, OSHA, and government guidelines. So the benefit to this is the wellness screening is going to be standardized and consistent to mitigate risk. We could have a standard form with a standard symptom screening, and the PPE is prioritized to the providers where it is most needed. Again, the provider will be the subject matter expert on which PPE is necessary for that particular incident of care. It'll allow the limited supply of PPE to be focused at the point of care for the patient and not to individuals that may or may not be involved in patient care at that period of time. Again, the providers can determine the appropriate type of PPE, and as the subject matter expert, the providers can perform the fit tests and the training necessary for that particular situation. This time, I'd like to turn it over to Linda Groh, the Executive Director and CEO of AORN.
Thank you, Rhett. Next slide, please. So right now, you're probably thinking, how does this apply to me as a provider? Well, Rhett just discussed all of the areas of ambiguity that we found as we started sorting through to revise this standard. This document provides a single set of standards for credentialing. It looks at the administration, the training, and the medical surveillance that are required. It identifies an interoperable process to verify credentialing in real time. It's been developed by subject matter experts who were advocating for the safety of patients, healthcare providers, and vendor representatives. All very important as we looked at the standard. Next slide. So how do you use these credentialing standards? Well, what's really important is that Joint Commission, for example, does not specifically tell you what you need to do about vendor representatives, but they do indicate that you must have a policy, procedure, or a guideline that really identifies how you control, how you manage, and also audit the process of vendors coming into your facility. It's a great resource because we identify 3 levels of access to the facility, and this will help you identify what your expectations are for each one of those areas. It also includes information, regulatory and standard setting agencies. And once you take a look at all those, develop your guideline, policy, or procedure, don't forget to include any relevant state regulations that should be included in the document. Now I'm going to turn it over to Dan Waldman.
Thank you, Linda. My name is Dan Waldman. I'm a senior advisor to the Medical Device Manufacturers Association. I have actually been working in healthcare policy for both medical technology companies as well as hospital systems for over 25 years now. Specifically working and representing today MDMA, which was founded nearly 30 years ago It's an organization that is focused on representing the interests of the entrepreneurial and innovative sector of the device industry. Most of our members are smaller companies. Often they have only a single product or technology platform. The first thing I'd like to note is that medical device representatives are really essential healthcare personnel for many procedures. And I really want to the work of AORN in this area as part of their overall mission to assuring patient safety and high quality outcomes in the operative setting, who had put together previously a position statement on the role of healthcare industry representatives in the perioperative settings. That document is available on their website, but I think the important part of it is it recognizes that the technical support and instruction provided by healthcare industry representatives is important to potentially decrease the time of the operative or other invasive procedures, and more importantly, facilitate the attainment of optimal patient outcomes. So medical device representatives and other healthcare industry representatives play an important role that is directly related to achieving optimal patient outcomes in the emergency room. As we moved past the restrictions on elective procedures that were imposed early in the pandemic and got into April and May, we started hearing numerous reports from our members of difficulties in accessing healthcare facilities, even when they were there to support a specific procedure. Some of these were mentioned by Rhett earlier, but they included inconsistent testing and screening requirements, inconsistent PPE requirements with regard to who would provide the PPE and what type of PPE needed to be provided, as well as requirements related to fit testing. And we agree that that was exacerbating a very difficult situation overall in increasing the competition for the PPE that was available in the marketplace. So toward the goal of that everyone shares, which is reestablishing access for patients to needed elective as well as emergency non-COVID care, we needed to develop some standardization or consensus around these issues. That is when we reached out, and I'd like to reference an original statement that came out. It was developed by AORN in conjunction with the American Hospital Association and AdvaMed, which is another organization that represents the medical device industry, developed a position statement which actually addressed a number of these important questions related to screening and PPE. This effort was really intended to move that position statement forward by incorporating it into the previously existing credentialing standard. And we were very pleased to have been able to take part in this effort. I want to reinforce what Linda stated, which is adoption of the standard is only the first step. And the much more important step, drawing upon my hospital experience, is for individual facilities to update their policies to reflect the consensus that is included in the credentialing standard document. And given the current situation that we are facing with COVID in the country, I hope that facilities will move forward with those changes to their own policies in advance of the standard being finally adopted. Again, we do believe it represents a consensus among all stakeholders. And I will also end by reinforcing that we believe that ultimately moving towards more standardized credentialing within the healthcare industry will be beneficial for providers, for medical technology innovators, and ultimately for patients. So thank you for the opportunity to be here, to be part of the process, and to address you today. And
thank you. Thank you, Dan. Thank you, Rhett, and thank you, Linda. Really appreciate your participation in this effort and your perspective on its need. So to discuss a couple of next steps, the document is anticipated to be published in the first quarter of 2021. When it is published, it will be available on the NEMA website, and an announcement will be made in the press when the publication has been finalized, including a link to where the document will be available. It is possible for parties to choose to align on the provisions in the revised standard in advance. They were referenced earlier on in this presentation. And for more information, or if anyone has any questions, they should feel free to reach out to me, Peter Weems, at pweems@medicalimaging.org. Again, thank you all for your interest in this work.